My name is Massimo Lanzaro. Max is the equivalent of Massimo in Italian. Max is the English for Max, basically. And I am a consultant psychiatrist. I work at present in Exeter, Devon.
Oh, beautiful place.
It is.
Do you know Kingsbridge?
Yeah.
I grew up in Kingsbridge.
Do you?
Yeah,
Oh, great.
So just to start off then, just describe to me a typical patient and what symptoms the schizophrenic patient might have, just in a profile.
The current trend is to divide symptoms of schizophrenia into positive and negative, to say. There's a chap called Crow that made this distinction. It has been quite it's quite useful, although there are more complex ways of describing schizophrenia, starting from Kraepelin at the beginning of this century, and then Bleuler and the Schneider, which they were all either Switzerland or German for some strange reason, but they are sort of the landmark of the different paradigms of conceptualizing schizophrenia. Right. The way we see schizophrenia now is, well, technically, is when a person experiences delusions, which are belief, which are held strongly, and which are against common sense, against the way everybody would see reality, the so-called normality, and are not shared by the common culture. So there are religious beliefs that might be regarded as delusional in some communities, and for other, but it's about the micro and macro environments. If we all believe that this is not London, maybe this is not London anymore. But since and the way a schizophrenic believes that he is Napoleon, for example, is exactly the same way we believe we are in London. So this is a symptom of schizophrenia, among the positive symptoms. Another symptom have to do with perception. The so-called voices, because what we know now is that these voices, the so-called voices, are something different, maybe something that is coming from what is called the sub-vocalizatory activity of the brain, but still what the person experiences is to hear like someone is talking to him. Most of the time is more than one person, and most of the time the things that these people hear are not very pleasant. Sometimes are really nasty things, derogatory things, or even worse, and this is where some degree of risk step in. They hear commands, voices telling them to do stuff. And the risk is when they tell them either to harm themselves or to harm other people. However, the proportion of mental health patients who are dangerous as the public sees this thing, it's comparable to the general population. I mean, there's a huge bulk of literature that says that there isn't a difference between violence in mental health and violence in the normal population, of a normal integrated guy after booze. So delusion and hallucinations, voices, are the positive symptoms. And then there's the negative dimension, which can be either a consequence of an acute episode. There's always the other side of the coin. And the other side of the coin is that when a person has realized of how unrealistic his thoughts were, and if treated or if, but there are lots of variables that play a role in that, but then the negative dimension steps in, which is loss of drive, low mood, lack of motivation, low energy, cognitive problems. The two phases can overlap, of course, and to make a diagnosis as far as the current criteria is concerned, well, they're slightly different, DSM-4 and the ICD-10, but they need to, for the DSM-4, they have to be there, the symptoms have to be there for 6 months, and for the ICD-10, 1 month. The ICD-10 is more oriented on Schneider's criteria. Whether the DSM-4 is more like it has its own trend. It's still influenced by the Schneiderian paradigm, but it has its own trend.
Thinking of a symptomatic patient with schizophrenia that you've treated with Seroquel, describe their life now compared to when they first came to see you.
I had different outcomes with Seroquel, to be honest. I had few negative outcomes and a lot of positive outcomes. So I couldn't describe one single life, but maybe I can think of I deal with acutely ill people because I work with inpatients or with people in crisis. I work with now they call it home treatment. It's home treatment or crisis team, whatever you call it. It's a sort of extension of the ward in the community. So you deal with acutely ill people, and sometimes you happen to deal with people who are experiencing those symptoms for the first time. And those are the cases where I had the best experience with quetiapine. Titrated to 600 milligram in 6 days. The person stayed in hospital for not more than, well, I've got 5 or 6 people that respond to this sort of description. Recovered, never admitted again. Now it's roughly a year that I haven't seen them anymore. And as far as I know, they're doing very well and they didn't have any relapse. The follow-up, sorry.
So you're giving back to the patient their normal life? Yes.
I think an important, yes, that's what happened to these people I'm talking about. I am sure, however, that it played a role, the fact that they were detected early. This drug, the quetiapine, as maybe other drugs, but quetiapine particularly, and this is my personal experience, works better with drug-naive patients.
How does that make you, I mean, to bring back some sort of normality for these patients who are obviously having a dreadful time, how does that make you feel to be able to do that for somebody, to bring them back?
How did it make me feel?
How does it make you feel?
Myself?
Yes, yourself, yeah.
Well, I guess that decreases the amount of frustration that is naturally part of this job. It's like rather a negative thing rather than a positive thing. You're there and you know that your job is to get frustrated somehow with our kind of patient, and you learn to cope with that, and there's supervision and a lot of other things. So you put that into you take that on board from the very beginning. You know that frustration is something that it happens with every job, but our job is we are particularly vulnerable from this point of view, and so the possibility of having some sort of relatively quick response and recovery, well, it certainly made me feel good.
It must make you feel quite proud to be able to see them recover. Yeah.
Definitely.
Very satisfying.
It's well, I have to say, in the place where I trained, I have been taught that the fact that people are recover, it's a starting point. Is not, that's not the goal. The goal is, well, on the patient side, is to improve the quality of their life more. I see a sort of continuum between psychiatry, psychotherapy, counseling, and then something more for the life of a person. It's just, I mean, the quetiapine stage, it's a stepping stone towards something which is much, much more. Or you wish it's much, much more on all levels: quality of life, cognitive improvement, and then now with the new ways of working for consultants, the quicker we get the patient better, the more time we have to invest in management, research, teaching, and that's important as well.
Okay. Next, what car do you drive and why?
I drive an Audi TT, and I like that car because it's sort of Art Deco, a bit old-fashioned, but very modern at the same time. And because it's reliable, because it's quite fast, and because it's stylish, and it's got some soul, it's got some juice into it.
Great, excellent. Thank you.
Thank you very much.